Okay, welcome everyone to the next Google Hangout hosted by MS Translate, and the fourth is part of our collaboration with the Melbourne Brain Centre. Tonight we have the pleasure of being joined by world-renowned neuro-ophthalmologist Dr. Owen White. So as you've seen throughout the week, we've been posting some work that him and his team are doing in terms of eye movement or ocular motor function, especially in people with MS. But without further ado, I'd like to hand over to Owen to give an introduction to himself and the work that he does. Thanks, Owen.
Thanks very much, Bruce. Thank you, Alan. I'm a neuro-ophthalmologist, and as Annika will tell you, that's a non-event, because neuro-ophthalmology is just a different way of approaching neurology, and it can be applied to many things. However, my primary interest, which was in eye movements, lends itself very well to investigating diseases of the brain, and one of our main areas of interest for many years has been multiple sclerosis. So although I'm not primarily a multiple sclerosis doctor like Annika, I do see a lot of patients, and a lot of our research, probably at the moment about 70% of our projects are related to multiple sclerosis. And in terms of clinical issues, we look at evaluating the visual system and how people see and how they move their eyes. But more specifically, the brain is essentially a computer, and notwithstanding that we all have been brought up to believe that we're only using 10% of our brain, the reality is that all of our brain is beavering away in the background all the time, processing information and making many decisions every second as to what to do, how to respond to situations. And the networks associated with this are incredibly widespread and interconnected at multiple levels. To give you a very simple example of what happens if we're walking down the street and we see two people walking towards us, and one of them is carrying a big chocolate cake and the other is carrying a large jug of water. If you're thirsty, you're going to be more interested in the person with the large jug of water, and if you're hungry, the chocolate cake's going to look pretty damn good. So you've got to make a decision as to apply salience to the two images, decide which one is more important, and you have to inhibit the other one. So you've got both attention there and you've got inhibition. Well, then before you make any response to that, you have to load all the information for the action into what's called working memory. Now, working memory is interesting because it probably only holds about 4 instructions at any one time. So you have to be able to shift things in and out of working memory very, very quickly. On top of that, I may well have been hungry, but there may be a little bit of thirst in the background as well. So I have to remember where that jug is so that I can look across at it after I've satisfied myself with the chocolate cake. So that's memory as opposed to working memory. Now, all of these processes crisscross the brain, and by changing the instruction sets we give to patients, we can evaluate their capacity to make appropriate movements and appropriate compromises between so-called top-down commands that are voluntary and bottom-up commands which are reflexive. So we've been doing that for quite some time because the eyes are very, very easy to measure accurately with regards to movement, and it's very easy to get some impression of brain function. Now, just to complicate things a little bit better, the reason everybody believes we're only using 10% of our brain is because the neurological examination, which is mired in the late 19th century, about 1875, it hasn't really changed since then, the way we examine the brain. And that only examines about 10% of the function of the brain. So that's what we do. We've extended the examination, the functional assessment of brain, getting towards the level where it can be compared against imaging, and we can get some value out of what we now know from molecular biology, both of which disciplines have improved incredibly over the last 20 or 30 years. That's me.
Okay. Thanks, Owen. Well, we'll just hand it now over to questions. Tony, do you have a question that you want to start us off with, or Brad, or Helen, Andrew?
Yeah. I'm still formulating. I hand over to Brad.
Um,
Sorry, Helen.
oh, no, Helen can go first. Yeah.
Oh, okay. Me, I was wondering, do you actually do examinations of people with MS, or do you study people with MS?
Yes, we
Both?
do. I do both. I mean, I have a clinical practice and a fair bit of that both in private and at Royal Melbourne is clinical work. I do more than half my time in clinical work, and the rest is done in the laboratory with the cooperation of a lot of people who have worked with me for quite a long time.
So what are the main problems you see in the eyes of people with MS?
Well, the commonest presentation I see in the eyes is loss of vision, optic neuritis. That people are very sensitive to loss of vision, and they're very sensitive to double vision. So the two common things I see are, one, loss of vision from optic neuritis, and of course there are a number of parameters that people may notice. But the other thing I often see is people who develop an eye movement abnormality and develop loss of stability of the images.
Do you see a lot of people with MS having eye problems associated with migraine as well?
You know, that's a tough call. I mean, migraine occurs probably conservatively in 15 to 20% of the community. So winkling out the visual disturbances that are due to migraine and the visual disturbances that can very occasionally be associated with MS is not particularly difficult. Migraine does produce quite similar, characteristic types of abnormalities. However, in migraine, you can actually get a lot of very peculiar abnormalities, including eye movement abnormalities and including visual disturbances that, although they don't quite have the characteristic of what you see in MS, they can actually go close. So that's a very small overlap.
Yes, because I'm just thinking that migraine sufferers have a lot of lightning bolt type disturbances in their eyes, and they can have little blindness, but not complete blindness, and it restores.
Well, migraine patients can actually have complete blindness, and it can actually very rarely remain permanently in place. Migraine's not an entirely benign disease. So, the lightning bolts that you see with migraine, what are called fortification spectra, can also occur in other diseases or things that look very similar, and they can occur in diseases that range from the retina, okay, to all the way back to the occipital cortex. So it's not. It has to be seen in context, and a decision has to be made as to where those sort of visual disturbances come from.
Okay, so as an ophthalmologist, you could examine someone and listen to their clinical story as well, and you could definitely differentiate between just a migraine and more your MS type of eyesight loss.
One never likes to be 100% and say anything. The reality is, if you look at all of the studies, with initial presentation of patients, if you take a whole range of patients, clinical diagnosis is correct in the best clinics at about 60% of the time. So I think that one always has to have, what you're doing when you see a patient is you're going through a process that will let you have a suspicion as to what the patient is, and then have a process for evaluating that patient to increase the certainty of the diagnosis, and that will depend on the story they're giving you. If somebody comes into me and says, I've had these flashing lights, I get a black spot in front of my eyes in the last 15 to 20 minutes, and then I get a headache on the other side, and then I throw up and it all goes away, I'm probably not going to think of much else but migraine. But there are a lot of different forms of migraine where you're left a little confused. Would you say that, I mean, Annika, you see a lot of migraine, you see a lot of people at the eye and ear as well. I mean, would you agree?
Yeah, no, I agree. I think it's you know, like migraine, you know, can be a great mimicker of other things. And you know, in a lot of the atypical type of visual phenomena we see, With migraine, we generally would, unless it's a classical story like Owen just described, we would think that it's, sometimes a diagnosis of exclusion. So you do have to sometimes think of other things as well that can look the same, especially when there's not a clear headache history, because a lot of people with migraine can get visual symptoms, or even unsteadiness and a vertigo sort of feeling without the associated headache that follows. So it's not common, but it does happen. And clearly, in those sort of things, you have to think, could this be something else? Although most of the times it is actually just migraine. So it's a very interesting disease. But I have to say, I guess with optic neuritis, Owen, the visual symptoms patients described with optic neuritis during the recovery stage and also down the track, you do get these sort of odd visual symptoms that people can have with, fluctuations in vision and, odd sort of tracking fast movements, that sort of thing can persist for a long time. But it is often related to stress and heat and fatigue, seems to bring it out. So that's sort of often what helps also when you take a history.
Yeah, I think there are a couple of things. Firstly, just to clarify what migraine is, most people think migraine is a severe headache, but only migraine is a syndrome of neurological dysfunction, and only 70% of the patients actually have headache at all. Excuse me while I mute that.
Oh my God.
Yeah, so a lot of people don't get a headache. I think that's what Owen's saying.
And of the 70% who have headache, only about 70% of them have severe headache. And the headache's not always characteristic. So that's one thing. The other thing about visual disturbances with optic neuritis is that they occur for many reasons. Partly they occur because you actually have nerve cells that don't function, so you lose vision. But later on in the piece, where some of the inflammation settles down, and you've lost some of the myelin, basically get short circuits between adjacent nerve fibers, and you get inappropriate responses. And funny, as Annika says, you get funny little flashes, you get vision that fluctuates. You can get almost anything. The two best ways of making a diagnosis of what's happening in a person, the two best tests are, one, the original consultation, and two, the passage of time. Now, they're also the two cheapest tests. Beyond that, you've got things like MRI and blood tests and electrical tests, which probably contribute 10 to 15 to 20% of diagnosis. But the passage of time is the best addition to the original clinical assessment.
So when you get the black spots, that is because nerve fibers have deteriorated?
Well, it's because not necessarily. It depends. The nerve fibers might be okay, but they may not be working properly. If there's been a bit of inflammation in the area, they may be, for want of a better term, stunned rather than killed. So the passage of time will tell you whether or not they're going to come back.
Yes.
And that's one cause of the black spots.
I just wonder because sorry Annika, you go on.
Oh, and I'm just wondering if you find that pre-existing history of optic neuritis in someone with MS, when you record their eye movements, does that influence the recordings at all?
Oh, that's a very interesting question, Annika. Annika is partly referring to a paper that was published out of Jerusalem several years ago that she, and I must admit I was quite excited about at the time, which showed that people who have optic neuritis process visual signals quite differently and produce eye movements that are different. And I think it's a very, very interesting proposition that because I think that, as I said before, these are multiple interconnected networks, and I think there's no doubt that they do affect eye movement production. The trouble is how they do it, because all of those patients had MS, and we are now seeing patients early on in the piece, so-called clinically isolated syndromes, who in many respects are probably the first presentation ever of demyelinating disease, MS. And we find almost universally that there are eye movement abnormalities. Now, the question is that because of the optic neuritis alone, or is it because of hitherto unidentified lesions? Some of the 7T MRI studies show that there's quite extensive disease even before you see the white plaques that we now associated with MS. The other thing that, Annika, that you're possibly not aware of is that we've been doing, not here but in Singapore, a little study on glaucoma, which is a pure optic neuropathy. And although it's a bit too early to be conclusive, it looks as though that pure optic neuropathy doesn't have the same effect on eye movements unless both eyes are affected. So, yeah. But that's very premature. Be prepared for me to be wrong. It's happened once before.
Andrew, do you have any questions you'd like to ask?
Yes, thanks, Brett. Owen, one of the things that I've perhaps observed over my experience of MS is that it seems relatively common that people have optic neuritis experience very early in their experience of MS, often quite severe up to and including blindness for a period of time. And they will often say, but subsequently I haven't had any experience of interference with eyesight. And I'm wondering, based on what you were talking about earlier, whether it's likely that in fact people are experiencing it, but they're not relating it to an optic disturbance. They're seeing things like vertigo as being some other driver rather than an optic driver. Do you have any conclusions around that?
Look, yes, I have an opinion. The fact is, and it's something Annika's heard me quote before, but it's not generally known. 49% of all nerve cells that enter and leave the nervous system are related to vision and control of eye movements. So it's half of all the input and output is related to vision and eye movements. When you put it that way, and you compare that with all the other modalities, hearing, balance, etc., etc., it's not surprising that we're going to be more sensitive to disturbances of vision than we are going to be to other functions. So when you put it in that context, it may not be that vision is proportionately more likely to be affected. It may be that it's just proportionately affected a lot.
Okay. Okay. That makes sense. Thank you.
That's a very good opinion, Owen.
Yeah.
Thanks, Annika.
Tony, Brad, do you guys have any questions that you'd like to ask?
Yes, thank you, Brad. Owen, can I please ask you about eye pain and how eye pain plays a role in your research?
Eye pain doesn't play a role in our research because we're primarily looking at the interaction between sensory information that we can control and motor output that we can record. Eye pain is an incredibly complex problem, and to be honest, when it walks into my practice, as it did the other day, my heart sinks for two reasons. One, it's often very hard to work out where the pain comes from, and two, it's often very hard to help the individual patient who's struggling with this. But eye pain can come from a number of different areas. You can have eye pain related to inflammation of the various structures in the eye, because most of them are pain sensitive, and even the choroid, which is outside the retina, it's the outer part of the eyeball itself, is very richly innervated with pain fibers. A lot of the pain that people feel in the eye is actually orbital pain, not necessarily eye pain. And the pain that people feel, for instance, with optic neuritis is related to inflammation of the nerve affecting the nerve fibers that are outside the optic nerve. Okay? So it's orbital pain, not specifically eye pain. Now, in multiple sclerosis or any other demyelinating disease, you can actually get eye pain because you have problems with the trigeminal nerve, which carries the signals for sensation from all over the face. It has a lot of pain fibers, so you can get what's called an atypical trigeminal neuralgia, which can be felt quite substantially in the pain in the eye. So it's a very complex thing to assess, and at this stage, the analysis of pain is very much a clinical analysis rather than a research analysis, particularly in the eye. There is certainly a lot of work being done on understanding the physiology of pain in the periphery generally.
Thank you, Owen. That helps me to not blame a GP from 15 years ago who I complained to about eye pain, and I was thinking that she missed all the signs that I had MS. So now I won't feel so bad towards her.
Tony, did you have eye pressure as well?
No, just this really crazy, when I looked to the extremities of my vision, I had this really searing pain. And I thought I would just report it to my GP and that would help me. Clearly it did not, which leads me to another question to Owen, which is how is your work being translated for GPs?
Good question.
Well, it's a long way from being translated for GPs at the moment. What we're trying to do is produce systems that will let us evaluate what's happening in large groups for a start, so that we can actually use it for the evaluation of overall progression of groups, and then look at it as a graded mechanism of looking at responses to new therapies, and some of which we're in the process of developing in other disease groupings. But it's also, we're trying to validate it by following a large group of patients so that we can actually correlate the physiological abnormalities that we see with the radiological abnormalities, not the conventional white spots, but brain volume and other aspects of MS changes. So we're trying to look at whether or not individual patients are responding to medication or whether they're showing continued progression of the disease. Because over the years, the accumulation of white spots is actually never correlated very well with clinical deficit. So we're getting we think we're closer to that. A lot of this is unpublished data at the moment. A lot of it's been submitted for publication at the moment, and a lot of it's ongoing work.
Yeah.
Cool. I think half of my questions already been answered. Owen, I'm just wondering, with the traditional path that most people with MS go down to diagnosis, you've got patient interviews, you've got an MRI if you're lucky, if you're really unlucky, the spinal fluid sampling and the like, fairly invasive things. And just wondering, the procedure of looking at the eye movement, is it recognised as a viable, if not a diagnosis tool as such, but maybe a pre-diagnosis indicator? And is it is the testing recognised and covered under Medicare at all?
No, it's not under Medicare at all. Look, I'm glad you asked that question, because this is something we're struggling with. You have to recognise the conservatism of the medical community in general. And everybody thinks that that's a bad thing, but it's not. It's actually a protective mechanism. So you actually have to prove things beyond doubt. Now, there's the reality is that what we are doing is that we have developed a series of tests that we believe that we will be attempting to distribute into some very large clinics here in the United States in the next few years, which take 5 minutes of time with a simple eye movement set up in our software. To give you a slightly different example, if we look at minor head trauma, we look at concussion. We have a project at the moment going with the NFL in the United States looking at footballers that have been hit in the head. And the tests are done on the sidelines in 2 minutes and give us a readout of whether or not neurological function is intact or not. So what we're in the process of doing is trying to establish that this can be useful clinically, that it can be done expeditiously, and that it will give us in this brief snapshot an overall picture of whether the brain is functioning at the level that it was functioning at 6 months earlier. And the advantage of looking at our stuff as opposed to conventional neuropsychology is that there's no such thing as a learning effect. So you don't learn the answers. You can't practice this stuff.
And I guess that, and just to follow on from that point, that links quite well with the paper summary that we put up earlier in the week, where I guess Brad talking a little bit about diagnosis of MS, but how the paper that you guys published suggested that eye movement tests could be a really good way of monitoring cognitive decline or progression of decline in people with MS. Is that one of the key things that you think might come out of this?
We've been able to show so far that what we're doing is the single most sensitive assessment of overall cognitive function in the brain that's available to date. And that's been generally accepted. It doesn't mean it's been generally implemented, but it has been widely accepted by people in the area that there is nothing more sensitive than what we do with brain function. Now, sensitivity is not always necessarily exactly what you want, because sometimes you're too sensitive and you can just say people are black or white. You can't say that. What we're trying to establish is gradation. We're looking at procedures that will let us look at whether you're black, white, or some shade of grey in between. And we think we've been reasonably successful with that, and we're, as I said, putting that, submitting that for publication now. And it's a cheap test to do. I don't think it'll ever be done in a doctor's office as such, but I do believe it will be done in large MS clinics. And I'm sure that Annika has an opinion on this, except she's just become a blue blur on my screen.
Sorry, I've got to run. Things are going crazy, but yes.
What I was going to say was that I think MS patients benefit from being in multidisciplinary clinic settings where a lot of these things can be done, and can be done by ancillary staff as well as they can be by doctors. A lot of patients are seen in private now, and I think we have a large group in our private practice, but we still don't have all of the facilities that I think MS patients deserve.
Yeah, that was part of why I was quizzing about the Medicare aspects was I would consider a big socio-economic impact on people with MS, and probably affects a lot of people getting the optimum diagnosis and treatment, is the MRI being such a highly valued measurement and test. You don't come cheap, that the average person's out of pocket about $1,000, and that has to have a major impact on people with MS and how their journey happens through this.
I think it's very complex, and I don't have an enormous amount of sympathy for the people who run our health economics, but I think it's also very important to understand the difficulty with dividing up the pie and deciding what is more important. I'm a neurologist. Everybody on this group has an interest in neurological diseases, specifically MS. We all think it's very important. The people who have cancer think that cancer is very important, and the people who have rheumatoid arthritis think rheumatoid arthritis is important. The people who divide up the health dollar haven't got any idea of what's important. And it's very, very hard to decide where do you put your dollars to get the biggest bang for your buck.
Prevention. Prevention.
Well, yeah, I think that's right. But that also involves widespread evaluation, and widespread evaluation is incredibly expensive. I mean, I had the opportunity to talk to the Prime Minister a little while ago at a lunch, and I said, and other people have said the same thing. Stop telling people they've got the best healthcare system in the world. Start telling them they've got the best healthcare system they can afford. And then that's not even necessarily true. There needs to be a lot of reorganisation and a lot of money spent in order to have a better healthcare system. But it is true. For what we spend on health, we have a pretty good healthcare system. I would much rather be here than in most European countries, and that's including Western European countries. I'd much rather be here than China or the Soviet, the old Soviet Union countries. And in fact, I'd much rather be here than many parts of the United States. The United States has the best medicine in the world, but it also has some of the worst. We have some of the best medicine in the world, but our worst is nowhere near as bad as theirs. So it's important not to rest on your laurels and think, oh, everything's hunky-dory. But it is important to recognize that it's incredibly difficult for a guy who's always driven a four-wheel drive and cut wood for his life's work to suddenly find himself in the Senate having to make decisions about healthcare and other sorts of things. Most of these people have no training or understanding of how to do this. And the healthcare economists often care about the dollar more than they do about anything else because that's what they understand. They understand dollars. They don't necessarily understand the requirement for services. You've heard my political diatribe. You can vote for me at the next election.
Open it up for more questions. Anyone got a question that they'd like to ask?
Yes, thanks, Brett. Oh, and I'm wondering with the work that you've done so far, whether you've formed a view that if you look out, I don't know, a decade or 2 decades, whether there will be treatments that might specifically target the optical area as distinct from some of the treatments that we have today that are more generic in the sense that they tackle the whole of MS rather than specific elements of it. Do you have any view around that?
I do, and it's probably a slightly heretical view in that I believe that anything you can imagine will happen. I also think that there are differential susceptibilities to inflammation in different areas. The big bang for buck at the moment would appear to be tackling control of the immune system and the dysregulation of the immune system, and that is a fairly general thing. I do believe that there will, in the future, be more attention paid to the specific issues in the visual system, if only because vision is such a dominant sensory system for us and so important for normal life. You can get by much better being deaf than you can being blind. People get more with numb feet, etc. But I think there will be more specific investigation of visual system issues in the future, but I think it will come after people feel that they've progressed as far as they can in looking at the general immunological issues, and I think that's where the biggest bang for buck will be.
Right.
Yeah, that's an interesting point, isn't it? Because there's quite a bit of a focus at the moment in the research world at trying to repair myelin, and that's a big focus, but that doesn't concern the eyes, does it?
Oh yes, it doesn't. The visual system, very much so, very heavily dependent on myelin. Many myelinated fibres in there, and for most of the people.
Do you mean in terms of the brain? The brain controls the eyes, and the myelin is in the brain.
And the myelin is. I mean, myelin's a very complex. Well, the cells that produce myelin are very complex, and they have many roles to play, including nutrition of cells, maintenance of the homeostatic milieu within which the cells live, a number as insulation, etc. But certainly within the visual system, and within which I'm separating now from the oculomotor system, there are heavily myelinated projections from the back of the eye all the way back to the back of the brain, where the visual receptive system is. So most people who have optic neuritis, they might lose some neurons, and we know that they do, because there's good evidence from looking at the OCT at the back of the eyes over years. But the vast majority of their damage initially is related to inflammation of the myelin, and that will sometimes settle down.
That's interesting. So does that mean like the remyelination will actually help your visual system?
Well, remyelination is not a particular issue because it doesn't occur to a great degree at the moment. But we do believe if we can promote remyelination, then we would certainly have better function. The trouble is that when you lose a lot of myelin, the nerve cell itself often dies off secondarily. So that you really got a number of levels there at which it operates. So most people don't lose all of their myelin in any particular attack. You have to be pretty unlucky to lose all the myelin around all of the nerve cells that are involved in a particular function. Welcome back, Annika.
Thank you.
Owen, I guess. Sorry, Brad, you go.
Sorry, I was just going to ask, with the actual testing, obviously with the health system, as you mentioned, the bean counters are doing their thing. Part of that is a big push in regional areas to e-health, this health over the internet type of scenario. And so I'm just wondering, the hardware you're using to actually do the testing, is it fairly simple hardware like the Google Glasses type of visual medium, or is it a VR goggle type stuff, or are we talking $1 million Apache fighter helmet, look down, shoot down system? I'm just wondering, would the hardware you're using be suitable for an e-health remote situation?
The system that we're using at the moment in the laboratory costs, to set it up fully, about $45,000. And there are no consumables, and it provides all of the information we're using. We've been using one of our systems for 4 years now, so $45,000 spread over 4 years is, and we'll be using it for another 3 or 4 years because it's in perfectly good condition, is not particularly expensive. You can do the tests in less than 30 minutes and you can run them all day, so it's a very cost-effective treatment. For the clinical purposes, we're trying to adapt a little system that comes in a case that's probably about the size of my MacBook that I'm talking to you on at the moment, slightly thicker than that, and it costs about $12,000 or $13,000, and it will give us all of the information that we require in conjunction with a simple computer. So the answer is that the system that we're talking about can be put almost anywhere and can be run by almost anybody who can tell somebody to watch the dots on the screen.
Actually, if you have a look, Brad, the video that we put up yesterday actually outlines one of the tests that that they do. So it actually showed one of the people that work in Owen's lab setting up the equipment, actually using Annika as our guinea pig. And shows that the headset that they use, how they put it on, and the sort of test that you go through, having to follow the dots on the screen, and then the sort of output that comes from it. So that was posted yesterday, so you should be able to find that on our page or on the YouTube channel. Question I had, Owen, just quickly. I guess one of the common things that we hear from a lot of people with MS, and one of the hardest things that people have to deal with MS, is the uncertainty of not knowing what's going to come next, because everyone sort of has very different outcomes in terms of the MS that they experience. In terms of using eye movement tests to sort of get a good indication of cognitive function and things like that, is there any sort of longitudinal studies that show that these eye movement tests and the sort of results that you get from them can have a predictive effect?
Well, we're the only longitudinal study in the world at the moment. We've been following patients for three years so far, with, depending on funding, we'll be following them for another 5 to 10 years. There are other people that have shown interest in this, but the interesting thing is one of the very large clinics in North America from the University of Texas Southwestern came along, and they were about to start up on this and looked at our stuff and said, oh, you're 5 years ahead of us. We'll just work with you. So we're in the process of now extending our stuff to the University of Texas Southwestern, and through them to their collaborators at Johns Hopkins and the New York University and University of Iowa, all of which are very large clinics. So that is going to be an ongoing longitudinal study, but also combined with the clinical setting, because it's already giving us clinical information. It may not be generally accepted, but it's quite, by the ruck of neurology or the rest of medicine. But it is actually giving very useful information that people who are working in MS can use, while we're still collecting the data that proves that it's useful.
Okay, well, we might sort of start to wind things up a little bit, so I'll hand it over to everyone to ask sort of one last question if you have for Owen. Might start with you, Helen.
Oh, Owen, I was just wondering whether you had a chance to watch those couple of little YouTube videos that I sent through the week. I had a before and an after little video of a lady who had quite pronounced problems with her eye movement, and then she had a treatment for a vascular issue, and she then had the same kind of eye tests performed on her, which was just, eyes following finger, looking at eye movement, and she had quite an improvement in her ability to do that.
I have to be honest and say, no, I haven't. I'm actually on ward service at Royal Melbourne at the moment, and I'm more than a before, so I apologise. I haven't seen that.
Yeah, it was very interesting, because a lot of people with MS do complain that they have a feeling of pressure behind their eyes, and when they get the pressure relieved from a vascular treatment, they just feel a lot better, and they say that they can see a bit better and the colours are brighter as well.
Yeah, look, I'd have to be honest and say that I'm not a great believer in the vascular approach to the treatment of MS, and I think the Italian and Canadian studies have certainly gone a long way to showing that any improvement that we do see is quite idiosyncratic in different patients, and doesn't actually come above the noise signal that we see in fluctuation in patients otherwise. There's another small study, or there's a study going on at the Alfred Hospital here in Melbourne that may provide...
That's a very large study, actually. A large study.
Well, not by comparison with the overall Canadian and Italian studies, but it is going to be a significant study. One of my colleagues is heavily involved in that. But so far, the information that we have, to me, hasn't been convincing. It's not something that I routinely recommend for patients, but it's something that is continuing to occupy the minds of MS neurologists worldwide.
Thank you.
Tony and Brad, do you have a last question that you'd like to ask through?
I think I'm all spent.
Thank you for answering our questions, Owen. It was great.
My pleasure. My pleasure.
Okay. Andrew, do you have a last question you'd like to ask?
Yeah, thank you, Brett. Owen, there's a lot in the popular press over the last few months around the issue of, or the opportunity, I suppose, of brain plasticity, and I'm just wondering, A, whether you give that any credence, and B, whether you see in the work that you do that the brain does adapt in any way given the confrontation of optic disturbance.
You know, it's a very big question, Andrew. The answer is I'm an implicit believer in brain plasticity. The fact is that you've got these multiple connections, and you know, if I break a single connection in this computer, it's off the air. When they put the space shuttle up, they put 3 computer systems into it in case something went wrong with one. By orders of magnitude, the brain has the capacity to alter the way in which it goes from point A to point B with probably 1,000-fold more so than those 3 computers can take over the function of one to another. The reality is that we measure very, very minor abnormalities that wouldn't interfere with clinical function, okay? But we see those abnormalities with our tests.
Okay.
Now, the disease is where those compensatory mechanisms break down. One of the things we are doing is we're developing, for want of a better word, cognitive exercises to see if we can train people to recover more quickly. And we're actually doing this in stroke at the moment with people with mild strokes, because a lot of people have strokes. Following their stroke still feel crap, when in fact, to our eyes, they've largely recovered. We've been able to show that they still have cognitive deficit in terms of impaired processing. And we're looking in that group who don't have an ongoing disease to see whether we can improve things. With the people at the University of Texas Southwestern, we're starting to look at MS patients, particularly those with fatigue, to see whether cognitive retraining might actually improve things if you can otherwise stabilize the disease. The problem is trying to develop plasticity in people who have a dynamic disease process going on. Right. So if you can stabilize the disease, then you can start rehabilitating people from there. And that's where I think plasticity comes in.
Okay. Thank you. And as others have said, thanks so much for the time and what you've shared. I appreciate it a great deal.
It's a great pleasure.
And just one last question for me, and I guess it'll sort of lead into the video that we're going to put up with you tomorrow in terms of upcoming studies that you have and how people can sort of get on board. But I thought while we're doing the Hangout, we might just give you a quick chance to talk about those studies if you'd like, and just talk about how people can get in touch if they're interested in participating at all.
Well, we've got a number of studies at the moment looking at the effects of medication, and one of them in particular is looking at the effects of famotidine, which is a drug, probably the only drug that's available at the moment for treating MS symptomatically as opposed to treating the underlying disease. And that is important for people whose disease may have stabilized but still have significant problems. And that's not a drug that's generally available now because of cost. So we are doing studies of that to see whether or not we can actually look at that. And we're looking for patients who are going onto famotidine, or patients who have been on it and are thinking of coming off it for one reason or another. We are about to, we believe, get funding for a larger study, continuing our longitudinal studies looking at the effects of the disease-modifying drugs and whether they actually preserve function as well as structure, or whether they just slow things down. So that study is about to come up in the next few months as a continuation of our ongoing studies. I guess the best way to contact us is through my PA at Royal Melbourne, it's Sue Hill, and the phone number there is 93424586, or her email is sue.hill@mh.org.au.
And then we will be posting a video to sort of sum up those studies again tomorrow, and all those contact details will be available in that video. Right. So I guess with nothing else to say, I'd like to sum up what everyone's already said and thank Owen very much for his time tonight. Obviously, he has a lot going on, and we all really appreciate you coming on board and taking the time to talk about your work and answer everyone's questions.
My pleasure.
For everyone else that's participated, again, thank you very much for coming on board and taking the time to join in our discussion. As we've said before, this doesn't work without you guys taking the time to come and join in as well, so thank you to you. And we look forward to the next discussion soon. Thanks, everyone.
Okay. Bye.
Thanks, Brett.
Thank you.
Bye.
Bye.